Grazie, anch'io ringrazio Edoardo e Luigi e ho deciso di fare la lettura in inglese perché mi sono accorta che si riesce a dire di più in meno tempo e voglio rimanere nei 15 minuti. Grazie. So, I will start with some basic clinical definitions. When we talk about central apnea, we actually refer to a cessation of airflow without effort. Obstructive sleep apnea is the absence of airflow, but the thoracic and abdominal muscle continue to move desperately in some cases. Hypoapnea is when there is not a complete apnea, but a decrease of at least 30% in airflow. We measure the hypoapnea index, which are the events per hours. Very important are also the arousals, and one parameter that is followed very carefully, particularly in the case of central sleep apnea, is the oxygen desaturation by 4%, because it appears that this parameter is the one that is linked to mortality related to sleep disorders. This is a common example of obstructive sleep apnea where you see the cessation of airflow at the top, but the thoracic and abdominal muscles continue to operate, sometimes in opposite directions, with the corresponding desaturation that you see in the lower graph, and the snoring index to complete the picture. This is central sleep apnea. As you can see here, there is cessation of airflow, complete cessation, and there is also no movement of either the thoracic or the abdominal muscles, with the accompanying oxygen desaturation. The most common denominator of all obstructive sleep apnea is the closure of the pharynx, and the pharynx is a very flexible structure, so even minimal amounts of fluid are sufficient to cause obstruction in that area. And in fact, this is why patients with heart failure have severe obstructive sleep apnea at night, just by the fluid shift that occurs from the standing to the supine position. The pathophysiology of sleep apnea, I'm sure, will be discussed more in depth by other colleagues, but as you will see, for central sleep apnea, even in obstructive sleep apnea, there is an activation of sympathetic activity, and all the consequences of hypoxemia. As one of my current colleagues wrote when he was at the Mayo Clinic, 46% of deaths in patients with sleep apnea occur at night and are sudden because of the stimulation of arrhythmias during the episode of sleep disorder breathing. And we know in obstructive sleep apnea for sure that the mortality increases proportionally with the number of AHIs. The higher the number, the greater is the mortality. And as you notice there, the real difference occurs when you have moderate or severe sleep apnea, designated as events going from 15 to 29 for moderate and above 30 for severe sleep apnea. The risk factors are numerous. Anatomy, this is very interesting. For example, it has been shown that Asians, particularly East Asians have obstructive sleep apnea even in the absence of obesity because of the anatomy of their mandible and the easier closure of the pharynx. Obesity, older age, male, family history is important, and smoking is another important risk factors. The symptoms, as you know, are very ill-defined. They are very non-specific, but what we find particularly useful is to collect information on nocturia, which usually indicates sympathetic activation during the night, and also daytime sleepiness more than fatigue. This is different from central sleep apnea because in patients with CSA we find yes, fatigue, but rarely daytime sleepiness as you find in patients with obstructive sleep apnea. There is certainly a causal relationship between obstructive sleep apnea and hypertension, and also there is numerous data showing that treatment of obstructive sleep apnea leads to better blood pressure control. I mentioned earlier that sleep apnea is associated with sudden cardiac death, and the number I already showed you, I already spoke of earlier, is that from midnight to 6 a.m., a sudden cardiac death occurred in 46% of patients that had obstructive sleep apnea, and in less than half of those that did not. There is, I understand, a lecture on treatment of obstructive sleep apnea, but I wanted to show you here the flow from the diagnosis to the evaluation of the severity in the center of the picture. If the patient is deemed to be a candidate for therapy, then they undergo a complete polysomnogram with overnight titration study, and then the true problem begins because, as you know, the major issue in the treatment of any sleep disorder is patients' compliance. The type of sleep apnea that I would like to focus on is central sleep apnea, primarily because we now are seeing the emergence of new treatment for this disorder. The other reason is that it's very prevalent in patients with heart failure. And actually, it is estimated that about 40% of patients with heart failure have central sleep apnea, which mutually worsens the progression of heart failure. The way I explain it to my patients, as I know, and I know is a very simplistic explanation, I tell them that because of their heart failure, they have an activated sympathetic nervous system. This, unbeknownst to them, while they are sleeping, causes periods of hyperventilation. With hyperventilation, there is a decline in CO2, and essentially the brain orders cessation of breathing to allow the CO2 to return to normal levels. The problem is that during the cessation of airflow, the oxygen level goes down, and the patient has the ill effects of repeated oxygen desaturations. I'm going to skip to what the Journal of the American College of Cardiology now alludes to as the central illustration of any article. Basically, Dr. Fuster wants the central illustration to represent the entire article. He says that what he wants is that a reader needs to be able to look at the central illustration and get the message from the entire article. So this is the central illustration for our review on the pathophysiology and consequences of sleep apnea. And first, I would like to draw your attention to the apnea-induced hypoxia and reoxygenation. This leads to two main consequences. One is endothelial dysfunction, which in turn will cause vasoconstriction, smooth muscle proliferation, and result in a thrombotic milieu, as well as in left ventricular hypertrophy and inflammation, which has adverse consequences on cardiac contractility and remodeling. In addition, there is an arousal-induced norepinephrine release with all the consequences of activation of the renin-angiotensin-aldosterone system, which is associated not only with hypertrophy but also with apoptosis, increased arrhythmia, sodium retention, and further activation of the renin-angiotensin-aldosterone system. I would like to let you know that I actually have this graph, especially the bar graph, laminated and in my pocket, and I take it with me when I explain to the patients central sleep apnea, because what I want to drive home to them is the fact that central sleep apnea is not a benign condition. And as you can see there, even having any central sleep apnea at all is associated with significantly increased mortality. And as you progress in severity, essentially the mortality associated with central sleep apnea is twice that of age-matched individuals that do not have the condition. And somehow I found that this graph really drives the message across the patients. One of my colleagues at Ohio State University has also shown that central sleep apnea increases the risk of heart failure readmissions, and the evaluation is similar to that of obstructive sleep apnea, except that the mask-based therapies so far have not been shown as effective as they are in obstructive sleep apnea. I'm sure you have all heard of the CANPAP trial. This was a trial of CPAP in patients with central sleep apnea. And the disappointing results were that although the CPAP therapy improved all respiratory parameters, it did not have any effect whatsoever on outcomes, hard outcomes in terms of all-cause mortality or mortality from heart failure. It turned out that, unfortunately, by the end of the study, only 39% of the patients were compliant with sleep apnea, with the CPAP, and the average duration of therapy was 3.6 hours. And when the authors did a post-hoc analysis dividing patients between those that had an effective inhibition of sleep apnea and those that did not, those in which CPAP had adequately suppressed sleep apnea had indeed improved survival as well. Mask-based therapy, which are currently being studied, are adaptive servoventilation. Essentially, the depth of breathing is sensed, and the device delivers different pressures in inspiration, expiration, and according to the depth of the breathing. There are several ASV studies that are currently ongoing, and that they have nearly completed their enrollment, such as SERVE-FF, ADVENT-HF, and CAT-HF, and we are waiting for the results of these studies. The one that I'm especially interested in showing you is the stimulation of the phrenic nerve for the therapy of sleep apnea. And the thought beyond this therapy is that neurostimulation provided unilaterally to the phrenic nerve restores normal sleep and breathing by stabilizing CO2, and is a fully implantable transvenous system which activates automatically when the patient sleeps. This is the device in place. There was earlier an acute feasibility study which showed significant improvement in all the sleeping parameters. And then there was a pilot trial which is going to be published very shortly in the JACC Heart Failure. And these are the main data from the pilot trial. You can see that there was a drastic reduction in the apnea-hypoapnea index in the episodes of central sleep apnea. But what was even more interesting to us was that there was a drastic reduction in arousals and a near reduction by 50% of the oxygen desaturation by 4%, associated with improvement in functional capacity. And currently we are conducting the pivotal trial with unilateral phrenic nerve stimulation. This is the algorithm of the study. Basically, all patients are implanted. The treatment group, the device is activated at 1 month after implant. In the control group, the device is activated at 6 months. We are selecting patients that have proven central sleep apnea. However, we as a guidance to identify these patients, we have provided the investigators a list that includes patients that have atrial or ventricular arrhythmias. In fact, we find central sleep apnea in patients with atrial fibrillation that do not have heart failure, patients with heart failure, patients that have nocturia, and patients that complained of fatigue but not necessarily daytime sleepiness. So to conclude, both obstructive and central sleep apnea are high prevalent in heart failure. They increase morbidity and mortality of heart failure. It should be included in the evaluation of all patients with heart failure. In patients with heart failure and obstructive sleep apnea, mass-based therapy have consistently improved outcome. This is not so in the case of central sleep apnea. We are awaiting trials of ASV, and phrenic nerve stimulation may be an alternative treatment which, if we reproduce the effectiveness of the pivotal trial, may be a treatment that is effective and simultaneously does not require compliance on the part of the patient because the device works automatically. And I just received an email this morning that one more implant was done yesterday, so we have 12 more patients to enroll to complete the study. Thank you very much. We do the questions at the end.